Hello, my name is Beatrice Wood. I'm a family psychologist and professor of psychiatry and pediatrics at University of Buffalo. Research shows that socioeconomically distressed single mothers are at increased risk for depression, and their children have worse asthma disparities. So learning how caregiver depression impacts child asthma is crucial in order to identify targets of intervention. Our study applied the biobehavioral family model to examine whether maternal depression impacts child asthma by way of insecure attachment and child depression. Bruce Miller, a child and adolescent psychiatry professor at University at Buffalo, and JungHa Lim, a child and adolescent development professor at Korea University, participated with me in this study. The Biobehavioral Family Model, or BBFM for short, is a model I have worked on for quite some time. A complete description and evidence supporting the model is found in the Encyclopedia of Couple and Family Therapy, edited by LeBeau, Chambers, and Brennan. The BBFM is a heuristic model which prioritizes family relational factors based on the evolutionary observation that the family social system serves as protection from and a means of adapting to social stress and adversity. If family relational processes are functional, the family will buffer family members from stress. But if the family process is dysfunctional, stress may be exacerbated, resulting in anxiety and depression and even consequent physical illness in family members. Children in socioeconomically stressful circumstances are especially in need of the best family functioning possible. As I mentioned, caregivers in single maternal families under socioeconomic distress are vulnerable to depression, and their children have the greatest asthma disparities. Dr. Lim, the lead author of this paper, proposed that caregiver depression may be a key factor contributing to negative child asthma outcomes. So we expanded the BBFM and tested what we call the Caregiver Depression Biobehavioral Family Model, which posits a cascade of effects by which caregiver depression contributes to caregiver child attachment security, which in turn contributes to child depressive symptoms, and which in turn negatively impacts child asthma through psychophysiologic stress pathways. While psychophysiologic stress pathways are not examined in this study, Dr. Miller, a co-author of this paper, has developed a model, which our studies support, that in asthma, depressive emotion dysregulation is accompanied by a predominance of parasympathetic vagal over sympathetic activation in response to stress. Because vagal activation is a mechanism of airway constriction in asthma, depression makes asthma worse. This pathway accounts for the mechanism by which the child's depression may negatively affect their asthma. In our study, we enrolled 202 children aged 7 to 17 with asthma in single-parent maternal families from a socioeconomically disadvantaged population. In a cross-sectional design, mothers and children completed the Beck Depression Inventory, the Child Depression Inventory, and children completed the Relatedness Questionnaire, which is an index of attachment security. Asthma symptoms were indexed by self-report and by spirometry to test airway function. Findings from structural equation modeling were consistent with our hypothesis that maternal depression is associated with insecure attachment, which in turn is associated with child depressive symptoms and worse asthma. In addition, we discovered that mother depression is also directly predicting child depression. While cross-sectional, our findings nonetheless suggest that caregiver depression and parent-child relationship security may be important targets for family systems therapeutic intervention in order to improve child asthma and reduce health disparities for children with asthma, and possibly other stress-related illnesses as well. I would like to point out that the flexibility of the BBFM supports variations in the model that would then make it applicable to other stress-related emotional and physical illnesses, as well as applicable for individuals of all ages. Applying this modeling approach to health disparities could help identify family relational pathways by which stress caused by socioeconomic disadvantage is transmitted to the children. At the same time, it could identify family relational patterns which buffer the children from socioeconomic stress. Such pathways would be crucial to enhance for families the face of recalcitrant social, economic, and racial injustice. I believe that a significant accumulation of evidence that socioeconomic stress and injustice is transmitted through family distress to the child could inspire advocacy for resources and approaches that would address the social injustice and family stress factors, potentiating children's diseases and emotional disorders. Now shifting gears. Although the BFFM was developed to support research, as a model of specific dimensions of family function, it has been applied to guide clinical family assessment and intervention in family therapy, child psychiatry, and family medicine programs. It is not a model of intervention and change, but it does help identify targets for family relational intervention, which are amenable to many different approaches to family systems therapy. Furthermore, I want to emphasize that the model was designed intentionally to be culturally neutral and globally relevant, and it has been used in other cultures. We would be delighted to be available by email to anyone interested in critiquing, making suggestions for our work, in discussing applications to area of research, education, or clinical intervention, or in collaborating. Thank you for listening and for interest in our work. Goodbye.